Hi and welcome. We would like to introduce Dr. Ileana Piña. She's the Professor of Medicine at Thomas Jefferson University and Chief Quality Officer for the CV line. Thank you so much for joining us today, Dr. Piña.
My pleasure.
So firstly, what do we know about the association and role of inflammation in predicting outcomes in patients with heart failure?
I think we're becoming much more aware of the role of inflammation. I mean, we've been hearing about inflammation for years. A lot of the trials that I will be talking about that today, actually, because a lot of the trials that were focused to try to appease or tame the flames, as we're calling them here, for inflammation did not work. And yet the factors like alpha-TNF, IL-1, IL-6 are high in heart failure, but particularly in heart failure with preserved ejection fraction. Those are the ones that we worry the most about. But I think we're coming to terms about that we can't ignore inflammation.
And is this consistent in different types of heart failure?
We think it's much more prevalent in heart failure with preserved ejection fraction, and it may be because of all the other comorbidities these patients have, like obesity. Obesity is a very, very pro-inflammatory status or state. And many of them are diabetics as well, and they have hypertension. So maybe it's the conglomerates of all those comorbidities together that make HFpEF more important in inflammation.
Have any studies been done looking at targeting inflammation to improve outcomes in heart failure?
Yes, absolutely. Very early on, I was a very young professor at the time. We were studying blocking alpha-TNF. One of the trials was called Renewal, because we had data that alpha-TNF contributed to bad stuff in the animal population and some human studies. But when we studied it in a prospective randomized fashion, it didn't work. On the contrary, the administration of the blocker actually worsened outcomes. So that was kind of abandoned. And now we have an IL-1 blocker. I think it's called anicanin, and it's been tested primarily in animals. It may be a good target, but I think the real question is inflammation friend or foe? Do you need to have some inflammation for the patients to get over whatever the acute event is, like a myocardial infarction, or an acute decompensated heart failure admission, or is it damaging? And so it may be levels, they kind of interplay. It's very complex.
Interesting. And are there any reliable markers of inflammation in heart failure?
Well, we have been using CRP, C-reactive protein, for a long time. And we know, for example, the C-reactive protein gets quite elevated when the patient is in the acute stage. But then if you do nothing, the CRP quiets down. And we use statins all the time. Statins are anti-inflammatory agents, but when tested in heart failure prospectively, it did nothing to outcomes.
And how well do our current guideline-directed medical therapies lower the inflammation burden in heart failure?
Well, the guidelines don't really tell you that when you're giving these drugs, you're doing it to lower inflammation. But I think we're starting to realize that the SGLT2 inhibitors that are newer, in our whole pharmacologic thinking may actually lower inflammation.
Interesting.
And we know they work fast. Whatever they do quickly because the curves split apart very early. And they do affect outcomes.
That is very interesting. Well, we honestly thank you for your time.
Well,
you have
problem.
A lot of insightful pearls that is going to be great for our attendees to take home and immediately put into their practice. Do you have any additional pearls that you would like to share?
The pearls for me are pay attention to your patients, listen to what they're telling you, and actually medicate them and really medicate them, not just what I call the salt and pepper approach, a little of this and a little of that. Really medicate them at the doses that have been proven in the trials to work.